Good morning. We are going to talk about obstructive sleep apnea. To begin, could you define obstructive sleep apnea for me?
Good morning. Obstructive sleep apnea is a sleep-related breathing disorder characterized by repeated episodes of partial or complete upper airway collapse during sleep, despite continued respiratory effort. Each episode produces a fall in airflow with arterial desaturation, hypercapnia, and an arousal from sleep. Severity is graded by the apnea-hypopnea index, or AHI, the number of apneic and hypopneic events per hour of sleep. Mild disease is an AHI of 5 to 15, moderate 15 to 30, and severe greater than 30.
And the difference between an apnea and a hypopnea?
An apnea is a reduction in airflow of at least 90% for 10 seconds or more. A hypopnea is a reduction of at least 30% for 10 seconds or more, accompanied by either a 3% desaturation or an arousal.
Good. Why does obstructive sleep apnea matter to the anesthetist?
There are 4 reasons. First, the anatomical features that predispose to airway collapse in sleep also make mask ventilation, intubation, and extubation more difficult under anesthesia. Second, these patients are exquisitely sensitive to the respiratory depressant effects of opioids, sedatives, and volatile agents, and they have a blunted arousal response to hypoxia and hypercapnia. Third, they have a high burden of associated comorbidities: hypertension, ischemic heart disease, heart failure, pulmonary hypertension, atrial fibrillation, type 2 diabetes, gastroesophageal reflux, and obesity, which independently raise perioperative risk. Fourth, they have a measurably increased incidence of postoperative complications, including hypoxemia, reintubation, atrial fibrillation, myocardial injury, delirium, and unplanned critical care admission.
How common is it in the surgical population?
Prevalence in adults presenting for elective surgery is estimated at around 1 in 4, with higher rates in bariatric and cardiothoracic populations. Importantly, up to 80% are undiagnosed at the time of pre-assessment, so the anesthetist must actively screen rather than wait for a diagnosis to declare itself.
You've mentioned screening. How would you screen a patient in the pre-assessment clinic?
The most widely validated tool, and the one recommended by the Society of Anesthesia and Sleep Medicine, is the Stop-Bang questionnaire. It has 8 yes or no items, each scoring 1 point. The mnemonic is STOPBANG: snoring loudly, T tiredness during the day, O observed apneas, P high blood pressure, B body mass index over 35, A age over 50, N neck circumference over 40 centimeters, G male gender.
And the score thresholds?
0 to 2 is low risk, 3 to 4 is intermediate risk, sensitive but not specific for moderate to severe OSA. 5 to 8 is high risk, and a score of 6 or more strongly predicts severe disease. I would treat an intermediate score as high risk if the patient also has uncontrolled hypertension, resting hypoxemia, an unexplained raised serum bicarbonate, or a daytime PaCO, 2 above 45 millimeters of mercury.
Why the bicarbonate?
A serum bicarbonate above 28 millimoles per liter suggests chronic renal compensation for respiratory acidosis. In other words, the patient is a chronic CO2 retainer. It is a simple, inexpensive surrogate for daytime hypoventilation and raises the suspicion of obesity hypoventilation syndrome.
Tell me about obesity hypoventilation syndrome.
Obesity hypoventilation syndrome is defined as a body mass index of 30 or more, combined with a daytime arterial CO2 above 45 millimeters of mercury, in the absence of another cause of hypoventilation. It is a more severe phenotype than OSA alone. Patients have a higher incidence of pulmonary hypertension, right heart failure, and postoperative respiratory failure, and their perioperative mortality is significantly higher. Around 90% also have coexisting OSA.
Right, back to assessment. What specific investigations would you order in a high-risk patient?
I would tailor investigations to the planned surgery and the severity of suspicion. A previous polysomnography report is gold standard. I would want to know the AHI, the nadir oxygen saturation, and if the patient is on CPAP, the prescribed pressure and adherence. I would document the resting SpO2 on air. An arterial blood gas is useful if the saturation is below 94% or the BMI is 40 or above. a 12-lead ECG to look for right axis deviation, right ventricular strain, or atrial fibrillation. If there are signs of pulmonary hypertension or right heart failure, an echocardiogram. And of course, a focused airway examination.
What features of the airway examination are you particularly looking for?
I assess Mallampati class, thyromental distance, mouth opening, jaw protrusion, dentition and neck circumference. I also look for limited cervical mobility and a short, thick neck. The combination of a high Mallampati, a neck circumference over 40 centimeters, and a BMI over 35 reliably predicts both difficult mask ventilation and difficult intubation. Previous anesthetic records, where available, are invaluable.
Would you ever postpone surgery in an OS a patient?
It depends on the urgency. For elective major surgery in a patient with severe untreated OSA, particularly with uncontrolled comorbidities, I would discuss with the surgical team whether deferral for sleep study and CPAP titration is justified. The evidence that preoperative CPAP improves outcomes is modest, but the opportunity to optimize blood pressure, glycemic control, and right ventricular function is worth taking. For urgent or cancer surgery, I would proceed, but with enhanced monitoring, opioid-sparing analgesia, and a planned high-dependency bed postoperatively.
Is ambulatory surgery ever appropriate?
Yes, in selected patients. The Society of Anesthesia and Sleep Medicine guidance is that ambulatory surgery may be considered if the OSA is known and treated, the patient is established on CPAP, the procedure is superficial or minor, postoperative analgesia can be provided without significant opioids, and there is a responsible adult at home. High-risk untreated OSA, or any OSA patient undergoing airway, upper abdominal or opioid-dependent procedures, should not be done as a day case.
Good, let's say you have a stop bang of 7 for a laparoscopic cholecystectomy. He uses CPAP at home. Walk me through your anesthetic plan, starting with premedication.
I would avoid long-acting benzodiazepine and opioid premedicants because of their respiratory depressant effects and the blunted arousal response in OSA. If anxiolysis is essential, a small titrated dose of midazolam in the anesthetic room with full monitoring is acceptable, but my preference is non-pharmacological reassurance. Critically, I would ensure the patient has brought his own CPAP machine and mask to hospital, with documented settings, ready to use in recovery.
Preoxygenation.
3 considerations: position, time and pressure. I would ramp the patient so that the external auditory meatus is horizontal with the sternal notch, the head elevated laryngoscopy position. In the obese OSA patient, I would also tilt the operating table head up by 25 to 30 degrees. I would pre-oxygenate with FiO, 1.0 for at least 3 minutes, ideally aiming for an end-tidal oxygen of 90% or more. And I would apply CPAP or PEEP of 5 to 10 centimeters of water through the circuit during pre-oxygenation, which increases functional residual capacity and prolongs the safe apnea time.
What's your airway plan?
I would plan for a potentially difficult mask ventilation and a potentially difficult intubation. I would have a video laryngoscope as my first-line device, a supraglottic airway and difficult airway trolley immediately available, and a clearly verbalized plan A, B, C, and D before induction. I would consider awake fibrioptic intubation for severe OS, a combined with predicted difficult anatomy, OHS, or a documented history of difficult intubation. For a routine laparoscopic cholecystectomy in a patient without anatomical red flags, video laryngoscopy after careful pre-oxygenation is reasonable.
Induction agents.
Titrated propofol for induction. For neuromuscular blockade, I would choose rocuronium, because it can be rapidly and reliably reversed with su-gamma-dex. For opioids at induction, a small dose of short-acting agents such as fentanyl or fentanyl. If I were running a REM-E fentanyl infusion intraoperatively, I might omit a bolus altogether. I would avoid long-acting opioids and long-acting benzodiazepines.
Why specifically rocuronium and su-gamma-dex?
2 reasons are: first, su-gamma-dex achieves rapid, reliable, and complete reversal regardless of the depth of block, which is particularly valuable in patients who tolerate residual paralysis poorly. Second, residual neuromuscular block is the single most common preventable cause of postoperative respiratory complications in OSA. and SUGAM ADEX reduces that risk more reliably than neostigmine.
What monitoring will you use?
Standard triple GBI monitoring, pulse oximetry, ECG, non-invasive blood pressure, capnography, and inspired oxygen and volatile concentrations. I would add quantitative neuromuscular monitoring, measuring the train-of-4 ratio, not just the count, with a target ratio of at least 0.9 before extubation. I would consider a processed EEG monitor such as BIS to help titrate depth and reduce overall drug doses. For severe OSA, OHS, pulmonary hypertension, or major surgery, I would cite an arterial line. Temperature, urine output, and depth of block monitoring as indicated.
What about ventilation strategy?
Lung protective ventilation throughout. Tidal volumes of 6 to 8 milliliters per kilogram of ideal body weight. PEEP of 5 to 10 centimeters of water, plateau pressure below 30, and recruitment maneuvers after intubation and before extubation. In a patient with known or suspected pulmonary hypertension, I would avoid both hypoxemia and hypercapnia, because either will increase pulmonary vascular resistance.
Tell me about your analgesic plan.
I would aim for multimodal, opioid-sparing analgesia. For laparoscopic cholecystectomy, regular paracetamol, an NSAID if no contraindication, port site infiltration with local anesthetic, and consideration of a bilateral transversus, abdominis plane or rectus sheath block. Adjuncts such as dexmed-atomidine, low-dose ketamine, or intravenous lidocaine reduce opioid requirements further. If systemic opioids are required, I would use short-acting agents, titrate intravenously, and avoid background infusions on patient-controlled analgesia.
Move on to emergence. What are the dangers?
Emergence is the highest risk phase for the OSA patient. There are 3 principal hazards. First, residual neuromuscular block, even subtle weakness, with a train-of-4 ratio below 0.9, predisposes to upper airway collapse. Second, opioid-induced ventilatory impairment, which is exaggerated by the OSA patient's blunted chemoreflex. Third, airway obstruction in a sedated, supine patient, which can also precipitate negative pressure pulmonary edema if the patient inspires forcefully against a closed glottis.
What specifically must be true before you extubate?
4 conditions. The patient is fully awake and obeying commands. The train-of-4 ratio is at least 0.9, confirmed quantitatively, not estimated clinically. Analgesia is adequate without oversedation. The patient is positioned head-up or semi-lateral, and reintubation equipment is open and ready. I would also consider extubating directly onto the patient's CPAP, particularly in established users.
Now, postoperative care. Where does this patient go from recovery?
That decision is made before induction, not at the end of the case. The principle is that the level of postoperative care should match the combination of OSA severity, anticipated opioid requirement, and surgical magnitude. For this patient, severe OSA undergoing laparoscopic cholecystectomy, I would aim for an extended PACU stay, at least 60 to 90 minutes beyond the standard discharge criteria, and then a ward bed with continuous pulse oximetry. He should resume his own CPAP at his usual settings as soon as he is awake.
And if you were having an open upper abdominal procedure instead?
Then I would plan a high-dependency or step-down bed with continuous capnography if available, because he would have a higher and longer opioid requirement and a greater risk of postoperative respiratory failure.
Tell me about supplemental oxygen. Any nuance?
Yes, an important one. Supplemental oxygen will correct hypoxemia, but in doing so it can mask hypoventilation. An OSA patient receiving nasal oxygen can maintain a normal saturation while the PaCO2 rises significantly. Supplemental oxygen should therefore be paired with either continuous capnography or genuinely close clinical observation, never used as a substitute for ventilation monitoring.
What about postoperative CPAP? Any caveats?
3. The patient's own machine, at his own settings, used as early as practicable. Heated humidification improves adherence. And after upper airway surgery, nasal surgery, or transphenoidal surgery, I would discuss with the surgical team before applying positive pressure, as it can disrupt the surgical site or introduce air into surgical planes.
Is there a particular postoperative night you would worry about?
Yes, the second and third postoperative nights. This is when rebound REM sleep occurs, with greater muscle atonia and more severe apneic events. Combined with residual opioid effect and any lapse in CPAP use, this is when delayed respiratory complications and unexpected deaths tend to cluster. Vigilance should not be relaxed because day one was uneventful.
2 short scenarios. First, same patient but pregnant in the 3rd trimester, presenting for cesarean section. What changes?
The prevalence of OS arises in pregnancy, particularly in the 3rd trimester, and is associated with gestational hypertension, preeclampsia, and gestational diabetes. I would strongly favor neuraxial anesthesia to avoid airway instrumentation and systemic opioids. I would site the block with the patient in lateral or full sitting position, manage aortocaval compression carefully, and use intrathecal opioids sparingly. Preservative-free morphine, if used, requires at least 24 hours of respiratory monitoring postoperatively. I would not discharge her from a monitored environment until I was satisfied her respiratory parameters were stable.
Second, a 5-year-old child for tonsillectomy with severe OSA. The key points.
3 points. First, pediatric OS is most commonly due to adenotonsillar hypertrophy, and severe disease confers a real risk of postoperative respiratory complications. These children warrant overnight admission with continuous monitoring, not day case management. Second, they are exquisitely sensitive to opioids. Codeine is contraindicated, and morphine should be titrated very cautiously, with consideration of non-opioid alternatives. Third, after surgery there is a small but real risk of post-obstructive pulmonary edema once the obstruction is relieved, so I would extubate carefully, positioned with the airway secured.
Final question. If you had to leave a colleague with 5 take-home messages about anesthetizing an OS patient, what would they be?
1. Screen every adult with stop bang and assume undiagnosed OS are in the obese, hypertensive, or atrial fibrillation patient until proven otherwise. 2. If the patient owns a CPAP machine, it comes to hospital with him. 3. Ramp pre-oxygenate with PEEP and prepare for a difficult airway every time. 4. Use quantitative neuromuscular monitoring and confirm full reversal before extubation. This prevents the single most avoidable respiratory complication. 5. Plan the postoperative environment before induction, not in recovery, and remember that supplemental oxygen treats hypoxemia but hides hypoventilation.
Thank you. That concludes this station.